Zozalapa, Tashilele, Lasso, Fiakulla. Namaste everybody. Welcome back to our channel, Jhigu Economy, the only place where we take terrifyingly dense carbon economic data and translate it into plain, everyday human language. Have you ever worked so hard on something only for it to become useless overnight? Well, welcome to my week. I spent 3 days researching this video, read the finance bill, compared what other countries do, drank far too much coffee, finally finished the script, and then the government said, "Nice video. Let's remove the tax." Seriously, Nepali budgets have far more plot twists than Nepali movies. At this point, even Netflix writers are taking notes. But don't just leave yet, because this isn't really a story about the 3% tax. It's a story about how governments keep changing their minds. Our finance minister introduced a health tax. Another removed it. This government brought it back, and before many people even understood what it meant, it was gone. So today, let's Jhigu this economy. Before Facebook comments decide who's right, let's first try to understand what actually happened. The government proposed a 3% health equity fee on services provided by private hospitals. Sounds simple, right? Well, economics has the habit of making simple things complicated. Let's say that your hospital bill is around 20,000 rupees. A 3% health equity fee is about 600 rupees. Now, social media immediately split into two teams. The first team went like, what's 600 rupees if you're already paying 20,000 rupees? Meanwhile, team 2 went like, healthcare is a fundamental right and nobody should be paying extra. Both sound convincing, but economists ask a completely different question. Not who pays the government, but who actually ends up paying. Believe it or not, these aren't always the same person. And that's where today's story begins. Now, here's something many people don't know. This is the Nepal's first health tax. Back in fiscal year 2008-09, when Dr. Baburam Bhattarai was finance minister, Nepal introduced a 5% health service tax on private health services. Fast forward about a decade. In fiscal year 2018-19, when Dr. Yuvraj Katiwara was finance minister, the government did the exact opposite. It removed the 5% health service tax. It also abolished the value-added tax, also known as VAT, on health services provided by private hospitals. So let's keep the score. 2008, introduced a health tax. 2018, remove the health tax. 2026, bring back a similar tax. A few days later, remove it again. Honestly, this tax has had more comeback than many Nepali singers. So the real question isn't who introduced it. The real question is, what changed? Did Nepal's healthcare system actually change? Or did government finances change? Or did policymakers simply reach different conclusions? That's the interesting debate. Now, here's something interesting. Normally, when governments introduce a tax, economists spend hours arguing who really bears the burden. Sometimes it's the businesses, sometimes it's the consumers, and sometimes it's shared. But this time, the finance bill didn't leave much room for guessing. It clearly said the health equity fee would be levied and collected on the service charges collected from patients by private healthcare providers. In simple words, the patient would have to pay. So if your hospital bill is 20,000 rupees, the additional 3% health equity fee would have been collected from you, the patient. That changes the debate. The question is no longer, will hospitals pass on the tax? The law said that the fee would be collected from patients. The real question becomes, who are those patients? Are they only wealthy families? Or are they also middle-income families who turn to private hospitals because they couldn't get timely treatment elsewhere? That's the real question we should be asking. Now, here's another assumption we hear all the time. Only rich people go to private hospitals. Really? Imagine this. Your father needs a heart surgery. The government hospital says, we can schedule it in 3 months. The private hospital says, we can schedule it as soon as tomorrow. What does your family do? Do they say, no problem, we're gonna wait for 3 months? Of course not. Many families borrow money, sell jewelry, take loans, call relatives working abroad. Nobody wakes up on a Saturday morning and says, you know what sounds fun today? Let's visit a private hospital. People don't usually go because they want luxury. They go because they feel like they don't have any other practical option. And that's important because if people don't really have an alternative, hospitals can pass on the part of the tax to patients. Which brings us back to our original question. If patients ultimately pay, who exactly are we trying to tax? Only wealthy households? Or also ordinary families trying to get timely treatment? That's where the real debate begins. So far, we've discovered three things. First, this is Nepal's first health tax. Second, the person who pays the government isn't always the person who bears the cost. And third, not everyone using the private hospital is necessarily wealthy. Next, we'll tackle the biggest questions. Would a 3% fee actually stop people from using private hospitals? What do other countries do? And why do some economists support this idea while others don't? So, if patients are the ones paying, will they stop going to private hospitals? Let's be honest. Nobody wakes up in the morning and says, "Today feels like a great day for surgery." Healthcare isn't like buying a new TV or a fridge. It's not like waiting for a Dasai sale. Imagine you're having a heart attack. You're not going to tell your doctor, "Can we wait until Tihar? Maybe there'll be a discount." When people need treatment, they need that treatment. Economists call this price inelastic demand. You don't have to memorize that term. It simply means that when prices increase a little, people don't reduce their demand very much because healthcare isn't a luxury, it's a necessity. That's why many economists believe that a 3% additional fee would probably not stop people from using private hospitals. Now, supporters of the fee say, if you're already paying 20,000 rupees, what's another 600 rupees? That's a fair question, but let's flip it around. Imagine two patients. One earns 5 lakh rupees per month. The other earns 50,000 rupees per month. Both receive the same 20,000 rupees hospital bill. Both pay the same 600 rupees fee. For one family, 600 rupees might mean skipping one coffee at Himalayan Java. For another, it might mean paying one day's grocery bill. So economics isn't just about how much people pay. It's also about who pays. Because 600 rupees doesn't feel the same to everyone. Yes, the most popular comment on Facebook. If you don't like private hospitals, go to a government hospital. That's a bit like saying, if you can't afford the rent in Kathmandu, just buy a house. Thanks, very helpful. Now, don't get me wrong. Nepal has many excellent government doctors. Many government hospitals save thousands of lives every year. But let's also be honest. If your family needs an MRI today or emergency surgery tonight, you don't always have the luxury of choosing. Sometimes the nearest available treatment is in a private hospital. People aren't choosing private hospitals because they love paying more. They're choosing because they want treatment, not because they want a premium waiting room with free Wi-Fi. Now, this is probably the strongest criticism. Nepal's constitution recognizes healthcare as a fundamental right. So many people asked, if healthcare is a right, why should patients pay another additional fee? That's a fair question, but here's the government's argument. A right doesn't mean healthcare is free to produce. Doctors need salaries, medicines cost money, CT scanners don't run on positive thinking, hospitals need funding. Every country has to answer one simple question. Who pays the bill? That's where the real debate begins. Not whether healthcare should be financed or not. Of course it should. The real question is, who should finance it? Now, you might be wondering, is Nepal the only country trying to raise money for healthcare? Absolutely not. Every country has a different recipe. The UK mostly uses taxes. Germany relies heavily on compulsory health insurance. France uses a mix of taxes and health insurance. Nepal, we also have a national health insurance program, but still we rely heavily on government spending, out-of-pocket payments, and private healthcare. Think of it like going out for Momo with 10 friends. The bill always arrives. Nobody argues whether it should be paid. Everyone argues who should pay. One friend says, let's split the bill equally. Another says, the person who ate extra Momo should pay more. Someone else quietly disappears and pretends to answer a phone call. Healthcare financing is a bit like that. Every country agrees that the bill must be paid. They just disagree about the fairest way to split it. So, where are we now? A A 3% fee probably wouldn't stop many people from seeking treatment at private hospitals. But not everyone using private hospitals is wealthy. Many families go because they don't have any other practical choice. And while every country finances healthcare, they all do it differently. Which brings us to the biggest question of all. If this fee was supposed to improve health equity, how do we know it actually would have? That's where the final plot twist begins. Now, here's something that many people missed. The government didn't simply call it a tax. They called it a health equity fee. And according to the finance bill, the money was supposed to be used for two purposes. First, expanding access to quality healthcare services, and second, building health-related infrastructure. Honestly, that sounds like a good objective. I don't think anyone would say, no thanks, please don't build better hospitals. The real question isn't the objective. The real question is, how do we know it'll actually happen? Think about it. Imagine your friend borrows 5,000 rupees. He says, bro, I'm joining an IELTS class. 2 weeks later, he's uploading reels from Mustang. You call him and tell him, bro, what happened to your IELTS class? He replies, Mustang was also educational. That's why economists don't stop at promises. They ask for results. 5 years from now, we should be able to ask, did government hospitals improve? Did waiting times fall? Were more doctors hired? Did access to healthcare actually become more equal? If the answer is yes, then supporters can say the fee achieved its purpose. If not, then the problem wasn't the objective, it was the implementation. Now, just when everyone was busy arguing on Facebook, hospitals were protesting, doctors were giving interviews, experts were debating, YouTubers were rewriting their scripts, and then the government suddenly withdrew their 3% health equity fee. Honestly, I think that my script changed more times than the finance bill. So, was the policy good? Was it bad? That's still open for debate. But here's the more interesting question. Why was it withdrawn so quickly? Was it because of pressure from private hospitals? Or was it because of public criticism, political negotiations, or did the government decide there was a better way? Those are the questions worth asking. Because understanding why policies change is often more important than simply celebrating or criticizing the change. But wait, there's one more question. What about the patients who already paid the health equity fee between July 17 and the day it was withdrawn? Will they get a refund? Will hospitals adjust future bills? Or will the money remain with the government? Honestly, that's just not an accounting question. It's a question of fairness. Imagine buying a movie ticket. Halfway through the movie, the cinema announces, actually, today's show is free. Your first question wouldn't be, interesting policy. It would be, can I have my money back? The same principle applies here. If people paid the fee while it was legally in force, the government should clearly explain what happens next. Because good policy isn't just about introducing a tax or withdrawing a tax. It's also about giving certainty to the people affected by it. Let's look at the timeline. Fiscal year 2008-09, Finance Minister Dr. Baburam Batra introduces a 5% health services tax. Fiscal year 2018-19, Finance Minister Dr. Yuvraj Kathiawar removes the health services tax and also abolishes the value-added tax on private hospital services. Fiscal year 2026-27, Finance Minister Dr. Swarnim Bagle introduces a 3% health equity fee. It comes into effect on July 17. Patients begin paying it, hospitals begin collecting it, and then, just days later, the government withdraws it. So here's my question. Not which finance minister was right, but what changed? What made a 5% health service tax appropriate in 2008? Why was it removed in 2018? Why did the government believe a 3% health equity fee was needed in 2026? And what happened just within a few days that led to its withdrawal? Because if we're going to change tax policy, the public deserves to know why. That's the conversation we should be having. Let's be honest, both sides have a point. Supporters say a small fee on private healthcare can raise money for improving the health system. Critics say patients, not hospitals, were going to pay the fee. And not every patient in a private hospital is rich. Many families borrow money, sell land, or ask relatives abroad for help just to afford treatment. So this debate isn't really about the 3%. It's about balancing four things. First is the affordable healthcare. Second is quality healthcare. Third is the government revenue. And fourth is fairness. That's a much harder problem than social media makes it look. Economics rarely gives us simple answers. Sometimes both sides have valid arguments. The health equity fee may have disappeared, but the bigger question hasn't. How should Nepal finance healthcare? Through general taxes? Through health insurance? Through contributions from private hospitals? Or through a combination of all three? That's the conversation Nepal still needs to have. And maybe, before introducing the next health policy, the government should answer one simple question for the public. Why is this policy better than the one we had before? Because good economics isn't just about changing policies, it's also about improving them. Let's just hope that the government doesn't announce another policy change before I hit upload. If you enjoyed today's video, hit like, subscribe to Jhigu Economy, and remember, in Nepal, sometimes understanding the budget is harder than understanding the disease. See you in the next one. Bye!